Greeting of the season. I'm Dr. Vijay Bharat. I'm an allergist and clinical immunologist with more than 25 years experience practicing in Pune. Food allergy is also a very important entity. And you can see in the picture how it is like a tip of iceberg, which is missed. And now the cases are also increased, like more than 7 to 8 times admissions. And even adults, previously it was thought that the adult allergy may not be there. But I will start with one of the doctor only as a BMS MD doctor. She's having a panchakarma therapy in Germany. And suddenly, after eating 5 to 6 peanuts, she had anaphylaxis. As she is in Germany and she was knowing about what symptoms and all, she was rushed to the hospital and she was given adrenaline. She recovered from that. So, if you see the past, present, and future, you can see such a significant five-fold increase into the cases. And we have to differentiate adverse reactions to food and food allergy. Any abnormal clinical response attributed to injection, contact, or inhalation of any food, a food derivative or a food derivative, like toxic and non-toxic or hypersensitivity, can also be there. Food allergy is a global concern, and avoidance of food allergens is the strategy along with rescue therapy in case of emergency. Proper diagnosis and food allergen avoidance are essential for disease management, safety, and improvement quality of life. Characterization of epitopes underway, like linear versus conformational epitopes, B cell versus T cell epitopes. And if you see, like most of the nowadays, it has been found that the cutaneous sensitivity into the children, like dendritic cells into the skin, they sensitize with these grain dust and all from the some foods, and then later on, as the child starts consuming the food, he will have a H2 inflammation, and which leads to the food allergies. And then the symptom starts. So from local to systemic symptoms. And it's very important. So these are the certain allergens like bind to the FCR receptors on the mast cells, dendritic cells, and then the basophils macrophages. Then mediators are released. Then they cause the symptoms like vasodilation, mucus secretions, smooth muscle contractions, and immediate hypersensitivity. So within 2 to 3 hours, most of the patients show the IgE mediated food allergy. And rest of the other patients where non-IgE mediated also can be there, like FIs, then enteropathy or proctocolitis. Those are rare cases and they also can present like a food allergy, but most of the time there is a like FIs, it is acute dehydration, but there is skin symptoms and respiratory symptoms are not there, like a choking or a proctocolitis, like bloody diarrhea can be there, like a fissure and piles. And then enteropathy, like an enteritis, the patient may have vomiting, loose motions, or bloody diarrhea can be there, weight loss and all. That can be picked up with that. But the cutaneous sensitivity symptoms will not be there. Some of the overlap can be there, like non-IgE and IgE mediated. We have to differentiate. But there, you may not need a actual standardized food allergy test. But when within 2 to 3 hours the patient shows the symptoms, with the GI as well as skin symptoms and respiratory and hypotension and like a shock-like status, it is a food allergy. It manifests in a variety of clinical symptoms. Major progress has been made in basic translational and clinical research, leading to a better understanding of the underlying immunological mechanisms that lead to the breakdown of physical and immunological tolerance against the food antigens, which can result in either immunoglobulin mediated reactions or non IgE mediated reactions. Lifestyle factor, dietary habits, maternal neonatal interactions play a pivotal part in triggering the onset of food allergies, including the qualitative and quantitative composition of the microbiota. These factors seem to have the greatest influence in early life. So even last 4 years, when myself and Dr. Ushali Bharat were working with the World Allergy Organization Allergy Prevention Committee for the prevention of severe food allergies and atopic march as a atopic dermatitis, we found a lot of new things and these we have to learn, like how the dendritic cell get a sensitivity and then the children may have atopic dermatitis and later on can go into as a gastrointestinal symptoms. Like even the GRD, 40% of the children have food allergies. Then rest of the like colics and all repeated ones, severe one, which leads to the TH2 inflammation slowly and has a multiple sensitivities. So these factors, it by the genetics, environment, like a lot of artificial fertilization, then pesticide use, then genome environmental interactions, epigenetic effects. Then male sex in children has been more. Race, ethnicity increase among the Asian and black children compared with the white children. Familial association, HLA, and specific genes, they are positive. So even the genetic studies also can be in the future. Atopy is when individuals have a specifically IgE sensitization, and then the positive skin prick test or serum specific IgE or component resolved diagnosis nowadays, which has been very well used in these patients. Hypersensitivity is defined as conditions clinically resembling the allergy that cause it objectively reproducible symptoms or signs initiated by the exposure to a defined stimulus at a dose tolerated by the normal subject. So the actual foods like peanuts, then nuts, or the mutton, chicken, fish, then spinach or mushroom, or even the some fruits or vegetables. They are rare, but still, or specifically the lentils in India. Milk allergy is very common, followed by the egg allergy, and then the lentils like tur dal, masoor dal, Bengal gram, and all. So it's a acute hyperreactivity, hypersensitivity reaction because of the immunological mechanism. A correct diagnosis of allergic disease must adhere to the following condition: compatible clinical history, positive to in vivo or in vitro test to prove underlying mechanism and etiology. So even nowadays, the serum specific IgE for the extract and the component dissolved diagnosis for the different epitopes on the food or proteins also can be analyzed. Environmental influences and genetic factors of the host underlie the immunopathogenesis of food allergy and its manifestations. Some clinical studies have revised our understanding of the cause of food allergy. For example, functional genetic variants in the IL-12 receptors B1, toll-like receptor 9, and thymic stromal lymphopoietin genes, and even IL-4 gene polymorphism have been associated with an increased risk of food sensitization. People exposed to higher levels of certain germ and weed killing chemicals may also be more likely to develop food allergies. A new study has shown, like the chemicals are called dichlorophenols. So GI tract forms a barrier to outside environment. GALT inhibits responses to non-dangerous antigens while mounting responses to pathogens. Intact food antigens may penetrate the GI tract but not cause clinical symptoms. Develop in genetically predisposed individuals when oral tolerance fails. Increase intestinal permeability to macromolecules. So the gut inflammation or leaky gut progression is very important in food allergies. Then again, viral gastroenteritis, premature birth, cystic fibrosis, they also can cause the problem. Some precautions, and if you see the packing of the food, the additives, preservatives, and all, they can trigger that, like colors and all. But there are a common 14 allergens like celery, cereals containing the gluten, then barley, oats, then crustaceans such as prawns, crabs, lobsters, eggs, fish, milk, molluscs such as mussels and oysters, mustard tree nuts, including the almonds, hazelnuts, walnuts, Brazil nuts, cashews, pistachios, and macadamia nuts, peanuts, sesame seeds, soybeans, lentils, as I mentioned, sulfur dioxide and sulfides, if they are added into that. Class 2 food allergens, the cross reactivity and associated with oral allergy syndrome, latex fruit syndrome. So pathogen related protein 2 group, the glucanase like latex, avocado, banana, chestnut, fig. Pathogen related protein 3 groups, chitinase like latex, HEV, B6, avocado. Then pathogen related protein 5, chromatin like cherry, apple, kiwi. So birch, bit V1 homologs like pathogen related protein 10 like apple, cherry, apricot, peach, pear, carrot, celery, parsley, hazelnut, and birch, bet V2 homologs like celery, mugwort, spice syndrome, propylene like containing latex, celery, potato, pear, peanut, soybean. So this cross reactivity also still we are learning after so many years, and we have so many charts. Like recently when I went to the Munster University Hospital, Germany, I brought the charts and we have to compare with that, like cross reactivity. Otherwise, the patient consumes this food, this oral food allergy syndrome, when there is a cross reactivity, the pollens and dust mites, the people feel like that is a primary allergy, but it is a cross reactivity. Immunological mechanism of food allergy has to be understood. Type 1 IgE mediated, Th2 promoted, type 2 IgG and complement mediated cytotoxicity, Th1 promoted, like specifically food intolerance and all. IgG immune complex mediated, Th2, Th1 promoted. Type 4 cell mediated, Th1 promoted, where the contact food allergy dermatitis also can be proved, where the patch testing is useful than the skin prick test or serum specific IgG. Adverse food reactions and food sensitivities, like toxic food reactions, or like a poisoning, non-toxic food reactions, food allergy which is immune mediated within 2 to 3 hours, like anaphylaxis, and non-IG mediated, as I mentioned about the pies and proctocolitis and even the celiac disease. Food intolerance, non-immune mediated, enzymatic, lactose intolerance, pharmacologic, like adverse reactions to tyramine, and undefined, like irritation from the spicy food. These are the classifications: IG mediated, IG and non-IG mediated, like eosinophilic esophagitis, eosinophilic gastritis, gastroenteritis. Non-IG mediated, already we talked about that, and even milk soy protein intolerance and Hinner syndrome, like lung disease due to formation of milk protein IG antibody immune complexes, milk precipitates in the bloodstream after it is absorbed from the GI tract. Now you can see the specific conditions where IG mediated, you can say acute urticaria angioedema, then type 1 and type 4, like where contact urticaria. Uh, Most common is the anaphylaxis, the IG mediated. Then food associated exercise induced anaphylaxis, then cross reactivity, which causes a oral allergy syndrome, immediate gastrointestinal hypersensitivity. So these are the typical key features. Where there is acute urticaria, the food commonly causes around 20% of the patients. Most causal food, primary major allergens are there. Direct skin contact lesions, the multiple foods can also be there. Anaphylaxis rapidly, most of the time, the 14th food we mentioned about that. Food associated exercise induced anaphylaxis, mostly the milk, wheat, celery, shellfish, these also can be there. Oral allergy syndrome, where most of the symptoms are around the eyes. Very unlikely the anaphylaxis will be there. The raw fruit or vegetables, cooked forms tolerated, but raw fruit and vegetables can call. And birch and apple, then prawns and the dust mite sensitivity can also be there. And major allergens, like whatever we discussed about the milk and the shellfish, the lentils, the nuts, these can be there when immediate gastrointestinal symptoms. And then combined IgE and cell-mediated, like delayed type of atopic dermatitis, has to do with food allergy. 35% of the children. Eosinophilic esophagitis also increasing nowadays, very difficult to treat. Oral steroids are given, and even the omalizone like molecules have shown a very good results. And eosinophilic gastroenteritis, very often eosinophilic inflammation can be there, multiple, and where the patient can have weight loss, edema, obstruction because of the then cell-mediated delayed onset chronic food protein-induced enterocolitis syndrome, FIs, the milk, soy, rice, oat can be there. Food protein-induced allergic proctocolitis, milk can be there. Allergic contact dermatitis, where the spices and fruit and vegetables can be there. Food allergy and GID, there are definitely pathological relationship, and younger children's less than 3 years, it has been shown. Infancy, this frequency can reach up to 40%. Pathogenetic cause effect relationship between these conditions, like chronic rhinitis, atopic dermatitis, diarrhea, is more frequently observed in children with coexisting food allergy and GID. Cutaneous sensitization, this concept is very important. Generally begins in early infancy, characterized by typical distribution, extreme pruritus, chronically relapsing course. Allergen-specific IgE antibodies bound to Langerhans cells play a unique role as non-traditional receptors. Double-blind, placebo-controlled food allergy challenges generally provoke a markedly pruritic erythematous morbilliform rash. Only some risk is there, so these double-blind, placebo-controlled food challenges are not done routinely. Nowadays, the component result diagnosis can have a very good accuracy. Food allergy plays a pathogenic role in about 35% of moderate to severe atopic dermatitis in children. And what are the predisposing factors? Concomitant diseases, asthma and other respiratory diseases, CVTS, mastocytosis, like childhood mastocytosis, early phase with the mast cell disorders, high risk of anaphylaxis, allergic rhinitis and asthma, even the psychiatric diseases, even ADHD, and stress factors also, they have a severity of the allergy. Concurrent medications, like beta-adrenergic blockers, ACE inhibitors, ethanol, sedatives, hypnotics, antidepressants, recreational drugs. Cofactors that amplify the anaphylaxis: exercise, acute infections, emotional stress, disruption of routine, premenstruational status. So even many of the patients, while having a flying, they had a severe allergies. Cross-reactivity, IG cross-reactivity often occurs between the allergenic molecules in close related species, well-preserved molecules with similar function present in widely different species that belong to same protein family, like tropomyosin in derpivotane in house dust mite, pain M1 in black tiger stream. Co-sensitization, genuine sensitization to more than one allergen source, Timothy grass and birch. Sensitization is not due to cross-reactivity. So skin prick test is easily available and all because the blood allergy tests are slightly costly. But nowadays, even the some component result diagnosis for the specific like milk or soy and all can be made in a cheaper one. Most important is the food diary so that we can differentiate the allergy and food intolerance. So most of the patients after 4 to 6 hours or another day they have symptoms with intolerance like vomiting or indigestion or all that is not a food allergy. And non-IgE mediated food allergy. So these other things what we discuss and we have to identify that and then we can unnecessarily we can avoid the costly test. IgE mediated repeated similar type of reactions are there. So within 3 to 4 hours, the patient shows a reactions and reproducible each and every time in a very smaller amount also they show the reactions. And here we can have the different epitopes. So that's why the component result diagnosis has shown a very good. So where the patient is non-affording for these advanced tests like immunocap or component result diagnosis, then we can go for the standardized skin prick test, hardly 100 rupees per allergen, and where the negative to predictive value is more important than the positive reaction. Even some of the foods, we can have a prick to prick test like kiwis and all. We don't have standardized extracts. So there we can dip the lancet into the pulp of the fruit and directly prick at the skin at the epidermal and we can find that. Then blood specific IG, immunocap, the extract levels are analyzed and accuracy is also good, around 7 to 80%. But to have a component result diagnosis, CRD, which is much useful in immunocap or another Alex uh, machine is there, which can differentiate that. And these basic components containing the proteins can be allergen source. Each allergen source contains many different allergenic protein. Each allergen component commonly has several different epitopes. Epitope is the actual three-dimensional binding site for an antibody, and production technique of allergen component can be biotechnological in recombinant form, purified form, original source, or even the component result. Like component also can be analyzed with the artificial intelligence. That's very so you can see the cross-reactivity component CCD over here, how amongst the food allergy or inhalant allergen, and we can differentiate it active allergy or intolerance. Even the immunocap ISAC, which is not available in India still, but in future it can be there. But the CRD also has been launched in India for the immunocap and Alex. So advantage of the CRD is quantifying IgE antibodies to a single allergen protein component rather than in a heterogeneous allergen preparations, providing a unique component-specific IgE antibody profile of the patient for personalized medical constellation of the symptoms, supporting a molecular level understanding of the patient's individual constellation of symptoms, like specifically exercise-induced food-triggered anaphylaxis, as well as where if you want to have a desensitization for the peanuts, like how the leaf study was done. Still, it is not available in India, but future will be there. There, it has a very good. So, better characterize the patient's sensitization pattern, better understand of the clinical risk for the reaction patient. Otherwise, unnecessarily only for the urticaria and angioedema, the patient should not carry the EpiPen. The scare can also be there. Otherwise, because of the that stress also patient can have actual false symptoms of anaphylaxis. Determine the presence of cross-reactivity between the allergens. Facilitate the food challenge testing with the increased knowledge of what to expect. select appropriate patients for specific immunotherapy, and customize the treatment plan. So you can see the components how and cross reactivity of these allergen components. Like for example, peanuts. Suppose RH1, RA1, 2, 3 is there, then only there are chances of significant anaphylaxis. Otherwise, the cross-reactive carbohydrate determinants and the lipid transfer proteins and storage proteins, these pollen-related proteins can also be differentiated. So, depending on the peanut, RH123, soy, glyam 5 and 6, wheat, omega 5 gliadin, milk, BOS D8, casein, egg, galdivan, omicoid. These are important for anaphylaxis. So food challenge test, double blind food challenge test should be done. But in India, it's still not done because if it is not been done with the double blind, the psychological reaction also can cause a problem. Elimination diets and food challenges elimination diets. So depending on that, 1 to 6 weeks, eliminate suspected food or prescribe limited or eat only diet or elemental diet, oral challenge testing, like physicians supervise, emergency room medications must be available. Basic elimination diet allowed foods like rice, fruit, pear, apple, grape, meat, lamb, chicken, vegetables like asparagus, beetroot, carrots, lettuce, sweet potatoes, butternut squash, others like black tea, rooibos, olive oil, sunflower oil, sugar, salts. No preservatives, no tinned or packet foods are allowed in this patient. The atopic patch test is an epicutaneous skin test in which allergens commonly associated with IG reactions can be used as a contact food allergy dermatitis. A positive atopic patch test can predict a late phase reaction following oral food challenge. A positive atopic patch test may detect clinically relevant late phase eczematus or GI reactions in infants and children. Management of food allergy, specifically, once we have a confirmatory diagnosis of food allergy, always the patient should have a adrenaline ready to use. In India, it is not available, so we have our own form, like our regular adrenaline in a 0.5 ml syringes, two syringes. For a 10 kg child, 0.1 ml, for 20 kg, 0.2 ml, or 30 kg, 0.3 ml. And these prefilled syringes, label it with the proper epinephrine, the date also, and keep it in the spectacle case and keep with the patients. Even the schools and all the restaurants and all that awareness. So this can be utilized. This is a very good where I was also in the faculty for the school programs. The anaphylaxis action plan can be there, and the event report also can be kept. The children also can be given a practice and the card of anaphylaxis preparedness. Even the teachers also can be trained on that. And suppose a patient has anaphylaxis, the patient should be kept under observation. Immediately, adrenaline intramuscular should be given, only adrenaline, adrenaline, adrenaline. And after that, to prevent the biophysic reaction, the corticosteroids also can be given. Or if the cutaneous sensitivity or the itching is there, then chlorpheniramine maleate and all. The patient should be observed under 12 hours. IV fluids also should be given properly. And then after that, the patient should be educated about that. Suppose next time, in a food allergy patient specifically, if he consumes the food, don't wait for the reactions, give the adrenaline. It's always better to, before the patient is gone to the hospital. And rest of the other like drug allergies and first that drug or the food or whatever the sting, it should be avoided from that. And then the rest of the management can be done. In the future, the elucidation of the gene environment interactions will be crucial for understanding the food allergy. Microbiome, that is, omic studies, are an emerging field of interest to define the allergy pathogenesis, and in a not too distant future, the microbiome could offer novel therapeutic possibilities. Probiotics in food allergy. The probiotics have been shown by numerous studies to be effective in allergy prevention, particularly in reducing allergen eczema at a rate of 9 fewer cases per 100 pregnant women. Concerning the probiotics, GLADP, McMaster Working Group Guidelines for Allergic Disease Prevention conditionally recommends the probiotic supplementation in non-exclusively breastfed infants, both at high or at low risk for developing allergy, but not in exclusively breastfed infants. Even there are some studies done where the probiotics in the pregnant woman and the high risk allergy in children was there, but still it has not been documented. The studies are happening. So, but the future studies will definitely help with these patients. So, even 2020, the omalizumab is an adjuvant in multiple food allergy in OIT, oral immunotherapy patients. So nowadays, recently 2022, omalizumab has been approved by the Food Drug Administration. It can be given in the multiple food allergy patients, which definitely reduces the gut inflammation. It reduces the mast cell binding with the IgE, and it improves the quality of life of these patients. And these children will not have a severe reaction after exposure accidentally to the foods. Avoidance is the first step, but omalizumab has played a very well role into that. So it is affecting the quality of life. Label should be properly. Restaurants and schools also always be prepared for the allergic reaction. So adrenaline has to be kept. Food labels, food allergen cards should be there in Indian like cities. The awareness is most important. The infant with at least one first degree relative with a history of allergic diseases, in particularly allergic rhinitis, asthma, eczema, or food allergy, is at a greater risk for developing food allergy. Appropriate timing of food exposure and use of probiotics and prebiotics for allergy prevention. Introduction of peanut containing foods. High risk infants early in life, 4 to 11 months. The LEAP study showed that the early introduction of peanuts significantly decreased the frequency of peanut allergy among children at high risk and modulated the immune responses to the peanuts. Even in India, the boiled peanuts have shown a very good results rather than the dried peanut. Allergen specific immunotherapy has been evolved long, and so that's why subcutaneous immunotherapy to RIS2 has shown a very good results. Even in children's, it has been already studied. Now, phase one clinical trials in the adults are also happening. Oral immunotherapy applied to reduce the risk of inadvertent reactions and not to modify the natural course of the disease. Tolerance in desensitized children disappears. The allergen is not ingested every day in therapeutic doses. However, research is ongoing and the future use of recombinant allergens, synthetic peptides, and ubiquitous therapy for desensitization in humans looks more promising. Food immunotherapy, development of standardized protocols for food immunotherapy to enable pooling of the results for various studies, continued long-term studies to determine the chances of cure, discover the biomarkers in predictive of favorable or unfavorable response to food immunotherapy, determine the safety and long-term outcomes of the multi-food oral immunotherapies, determine safety and efficacy of the novel biologic therapies, dupilumab, anti-siglec-8 antibodies, ibrutinib, and development of the modified vaccine. Natural history, how long will my child's food allergy last? There is a relationship between symptom severity after the ingestion and likelihood of outgrowing the problem. And more severe the reaction, the less likely that the food allergy will be outgrown. Factors such as serum IgE antibody levels and age at diagnosis have also been associated with the prognosis of the food allergy. Milk allergies half-life is approximately 2 years, while egg allergies half-life is approximately 4 years. Peanut allergy, once considered to be a lifelong condition, can resolve in up to 30% of the cases. While peanut, tree nut, fish, and seafood allergy are mostly persistent conditions, little is known about the natural history of the allergy to such staples as fruits, vegetables, cereals, and meat. In food allergic children, tolerance must be tested by oral challenge at regular intervals. Often, tolerance is not acquired suddenly, but there is a gradual increase of the doses tolerated to challenge. Even after years of apparent clinical tolerance, gastrointestinal symptoms of food allergy and reduced growth need to inform, educate, power, provide support, give hope. The prompt diagnosis post-event, early referral and access to support, accurate information, misinformation should not be there because still a lot of mm, doctors also feel that nothing can be done for the food allergy, but it is not that way. Balanced approach to management by people that understand the life with the food allergy is critical to improving the quality of life. So combining from patients, from the community awareness from primary family physicians, pediatricians, dermatologists, ophthalmologists, chest physician, ENTs, and all. We can have a preparedness for that. And definitely, we can. Everyone has a role to play in managing food allergies, education, provision of information. Ongoing support is key to improving the quality of life. Unmet needs determine the prevalence and burden of food allergy in the countries like Asia, India, identify the relative importance of individual foods as relevant allergens for the specific populations, describe the natural history of food allergy in various populations, IgA or non-IgA or food intolerance, to determine the burden of food allergy among the adults also. Food allergy is rapidly increasing in India. Clinical correlation is necessary with standardized tests, specific IgE component result diagnosis. Use of allergen components is rapidly evolving, increases the possibility of managing food allergy in patients with a more individual approach. Using CRD, we can do better diagnosis, prognosis, and grade the food allergy also. We can also get help in deciding which patient should receive oral food challenge test or not. Routine standardized specific IgE testing with skin prick or blood specific IgE with molecular diagnostic offers a number of benefits that give a higher diagnostic precision, allow for better management. Gold standard is double blind oral food challenge test, but difficult routinely. Oral food immunotherapy is efficacy is increasing OFC thresholds. So great progress in food allergy diagnosis management therapies in the past 2 decades, but more work is needed. So positive approach is very important. Thank you. Thanks a lot.